Greetings, everyone. This is Miss Gibson. So in this lecture, we're going to be talking about acute kidney injury as well as chronic kidney injury. So when you think about acute, this just means something that is happened acutely within the last 6 months. Abrupt, rapid decline in renal filtration function is how the book describes it. If you look here, you'll see your serum creatinine as well as urine output. You need to make sure that you're familiar with oligouria as well as anuria, and make sure you know what that means. With acute kidney injury, the pre-renal, this is an adaptive response to severe volume depletion or hypotension. If your patient has hypotensive disorders or they're hypotensive, why would this affect your kidneys? Think about your volume. Think about blood flow to the kidneys. If your patient has low blood pressure, what's that going to do to your kidneys? Next is in response to cytotoxic, ischemic, or inflammatory insults to the kidneys with structural and functional damage. And then last is post-renal. This is from the obstruction of passive, I am so sorry, from obstruction of passage of urine. With your pre-renal, this is renal losses such as with diuretics, polyuria, vomiting, diarrhea, burns, hemorrhage, pancreatitis can also be an issue. Anything that's going to cause decreased cardiac output. Anything that's going to cause vasodilation like sepsis, anaphylaxis, drug overdose is another good one. Hypovolemia, heart failure, liver failure, even sepsis. Intrinsic, this is something that attacks the organ itself. So it is a structural injury. Renal artery obstruction, renal vein obstruction, malignant hypertension, sclerodermal renal crisis, could even be a transplant rejection issue. Some glomerular causes include anti-glomerular basement membrane disease, which is part of that good pasture syndrome. Make sure that you look at your resources for that. Lupus, which is an autoimmune disorder. I do not know why I keep getting tongue-tied. Some drugs like lithium, penicillin, cephalosporins, NSAIDs, proton pump inhibitors, things like that can definitely cause the structural or functional damage. Your post-renal, this is a mechanical obstruction of the urinary collecting system. It includes the renal pelvis, ureter's bladder, or urethra. Results in obstructive uropathy or post-renal AKI, which is what your book says. I have not had enough caffeine, evidently. Your assessment is going to be the same, a good head to toe. You're going to check your labs that the doc orders. They may order some imaging as well. Interventions: avoid hypotensive episodes, reduce exposure to nephrotoxic medication. Any kind of new edema, you want to check into that, monitor their labs. You're going to report all of that to your doc. They will be on a special diet. And then you're going to do some good patient education as far as with their discharge instructions. So your chronic kidney disease, this is a term that encompasses all degrees of decreased renal function, from damaged through mild, moderate, and severe kidney failure. It is progressive and irreversible. You do have 5 different stages there. It all goes by your GFR. So make sure you know what your GFR means. What does it do? How does it work? Look at your resources. So your stage 1, this is kidney damage with a glomerular filtration rate at a normal or high level greater than 90. Stage 2 is a mild decrease, GFR 60 to 89. There is going to be blood and protein in the urine. Treatment for stage 1 and stage 2 is focused on reducing the risk factors. As we go to stage 3, the GFR is 30 to 59. Some symptoms here, it's going to get progressive, so they're going to be fatigued, a lot of fluid retention because the kidneys aren't doing what they need to do, a lot of kidney pain. They're going to have a lot of labs. The focus will be slowing the progression. Of course, you're always going to do head-to-toe assessments and monitor the labs. Stage 4, this is a GFR of 50 to 30. They're going to have a lot of nausea and vomiting, just as uremic acids, other things build up in the blood. Difficulty concentrating, bad breath, taste changes. They will need to be hemodialyzed or some kind of dialysis, and possibly begin the discussion of kidney transplant. Stage 5, loss of appetite, nausea, vomiting, itching from those uremic acids, little to no urine, so they will need to be dialyzed as well. Body changes. With the kidney, it means your kidneys with CKD. It just means your kidneys are damaged and can't filter blood the way that they should. It's called chronic because the damage to the kidneys happens slowly over a long period of time. This damage can cause waste to build up in your body. CKD can also cause other health problems, such as high blood pressure, which is a major factor. The kidney's main job is to filter extra water and waste out of your blood to make urine. To keep your body working properly, the kidneys balance the salt and minerals such as calcium, phosphorus, sodium, and potassium that circulate in the blood. Your kidneys also make hormones that help control blood pressure, make red blood cells, and keep your bones strong. Patients with CKD have 10 to 20% increase in extracellular volume, including blood, putting patients at risk for fluid volume overload. What will their lungs sound like? Will they have crackles? Will their lungs be clear? Think about what fluid volume overload does to the lungs. Metabolically, your urea as well as creatinine excretion are disruptive. Creatinine, we know that creatinine comes from proteins in skeletal muscles. There's going to be acid-base changes. In the very beginning, blood pH is not affected, but as it continues, it's going to cause high levels of bicarb and high potassium levels. So, your calcium phosphorus balance, your kidneys control the balance between calcium and phosphate. So it is important that the levels of phosphate and calcium remain normal. The phosphate builds up in your body and binds to calcium, which in turn lowers your calcium level. Early CKD affects the level of phosphorus excreted, and with high levels, this means calcium is decreased, which is very dangerous. Let's see. Chronic kidney disease also causes reduced production of vitamin D, which facilitates absorption of calcium. So, what does that mean? If your body is not producing or doesn't have enough stored calcium, why is that an issue? What if you have too much calcium? If we have too much calcium and phosphorus in our system, that means that some of these crystals may cause some blockage, may cause some obstructions in your kidneys, in your heart, in your lungs, any of your vascular systems. Can also build up in your joints. So that leads to significant vascular disease. Cardiac, of course, I've already said, high blood pressure. The kidneys make renin, which is an enzyme that helps control blood pressure. When blood pressure is too low, healthy kidneys release renin to stimulate different hormones that increase blood pressure. Damaged kidneys may release too much renin, which can lead to high blood pressure. High blood pressure increases the risk of heart attack, congestive heart failure, as well as stroke. Anemia, the kidneys manufacture a hormone called erythropoietin, which tells the bone marrow to make more red blood cells. If your kidneys are damaged, your erythropoietin levels can fall, and your body will not make enough red blood cells. You could also have pericarditis. Uremic pericarditis is thought to be the result from inflammation of the visceral and parietal layers of the pericardium by metabolic toxins that accumulate in the body owing to the kidney failure. So, common associated signs and symptoms include low-grade intermediate fever, dyspnea, and tachycardia. Dyspnea and tachypnic episodes. So sorry. Let's see. Some other body changes would be your hematological and immunity issues. Having kidney disease or even kidney failure can weaken your immune system, making it easier for infections to take hold. In fact, doctors and researchers have found that most infections like those caused by pneumococcal diseases are worse in people with kidney disease. With anemia in CKD, the kidneys don't produce erythropoietin. Thus, you have a reduced amount of RBCs, which can also result in low iron as well as low folic acid. Gastrointestinal changes, they're going to have a fishy or uremic breath, which is usually considered a consequence of an increased salivary ammonia concentration secondary to bacteriuria. Uremic stomatitis. This is characterized by a coated tongue, painful ulcerations of the mucous membranes, as well as a metallic taste. So health promotion, treatment of hyperlipidemia, glycemic control, good patient education on avoiding nephrotoxins such as IV contrast, NSAIDs. Some medications that might be given is some renin, angiotensin system blockers. ACE inhibitors might also be given, ARBs or angiotensin receptor blockers in patients with proteinuria. So it just depends on what the causative factor is. Your assessment going to be the same, good head to toe assessment, labs and imaging depending on what the doc orders. Your management, fluid volume, pulmonary edema, all of these things are very, very important. And if you look at them, if you don't do good patient education with the patient or the caregiver, they're going to lose function of their kidneys. They're going to end up needing to be dialyzed, so sorry, or on a transplant list. Just make sure that you realize if the patient needs a kidney transplant, there are millions of different factors that go into that. They can't be, like alcoholic, they have to be on certain medicines. Many different things go into getting on that list. And there are several patients already on that list, so it depends on how critical their kidney disease is, how bad it is, what the prognosis is. A lot goes into that. So I will put something under extra resources that talk about getting put on or getting placed on the kidney transplant list. Once again, if you have any questions, please email me. If I have confused you or misspoke in any way, please let me know. I'm only human and I will make mistakes. Thank you.